Hello everyone, my name is Rado. I did this presentation on bacterial meningitis. So let's get started. Our agenda for today, we will meet our patient. We'll discuss his symptoms and his relevant history. We'll discuss his physical findings and his diagnosis, as well as the specific diagnostic test that we will be conducting based on his very particular diagnosis, and as well as his treatment plan. So let's meet our patient. Our patient name is DJ. He is a 19 years old Caucasian male, accompanied by his roommate. He presents to our medical clinic, complaining of worsening headache, fever, and a stiff neck that began a few hours earlier. He also describes chills and nausea that has developed overnight. Upon further evaluation, the patient lives in a campus dormitory. According to the patient, he has no known allergies to food, medication, or environmental. His past medical history is non-contributory. He has not seen a physician, however, since he was 12 years old. His family history is as follows. His father died at the age of 73, about 3 years ago, from a stroke. Mother has epilepsy, and his sister has hypertension. He denies any past surgical history, denies being on any medication. His social history reveals recreational marijuana use and periodic alcohol indigestion. So, his physical exam, his vitals are as follows. He does have a temperature of 103.5. Blood pressure is 95/62. Heart rate is 121. Respiratory rate is 20, and he's setting 99% on room air. His general appearance. The patient is in no apparent distress, but he is oriented to person and place only, but not to time. And he has no focal neurological deficits. For a clinical presentation, the patient's roommate, who is present during the exam, states that the patient seems more lethargic and had difficulty maintaining his balance. A petechial rash is noted on parts of the patient's trunk, extremities, and wrists. His skin is also cold. He also tested positive for Kernig and Prudeniski sign. The remaining examination are all within normal limits. So we decided to do a CT of his head, which in this particular case scenario, CT of the head is needed before LP only if the patient is exhibiting signs suggestive of intracranial pressure that is increased, altered mental status, which is the case for our patient, focal neurological deficit, and signs of meningeal irritation, which is also the case for our patient, in order to assess for ICP and to reduce the risk of brain herniation prior to LP. When we did the Kernek sign and the Prudeniski neck sign on this patient, he did test positive for both of them. So what are those two exams? The Kernek and the Prudeniski neck sign are physical examination findings that suggest meningeal irritation and are manifested as the body's way to avoid stretching the meningitis. The Kernek sign, as we see on the left side of the screen, is resistance to passive extensions of the flexed leg when the patient is laying supine. And Prudeniski neck sign, which is on the right side of the screen, is the involuntary flexion of the legs, flexion of the hips, I'm sorry, and the knees when the examiner passively flexes the patient's neck. These signs are classically used to test for the meningitis. So, in order to diagnose bacterial meningitis, we look at the classic presentations. We look at the Kernek and the Prudeniski sign, which he tested positive for both, and the physical examination findings. For the diagnostic studies, our patient has a fever, has signs of meningeal irritations and petechiae which indicates coagulopathy. The rash that is seen on the initial exam are petechiae. As we can remember from the earlier chapters, that these are small hemorrhages, localized areas of bleeding from the capillaries. They are present in about 50 to 60% of patients with bacterial meningitis. Therefore, this patient is exhibiting such a strong clinical suspicion of bacterial meningitis. A complete blood count would be useful to evaluate the patient for infections and thrombocytopenia. Coagulation studies should also be ordered, including PT, INR, APTT, and D-dimer. There is a concern for meningeal irritation, so LP should be obtained, cultures, cell count, and chemistries, and cytology. The rationale behind ordering those are as such. The culture of the fluid is also a standard test and detects the type of bacteria, if any, that may be present. Cerebrospinal fluid analysis is useful for determining the etiology of meningitis. In bacterial meningitis, the opening pressure upon LP is usually marked as elevated. The LP examination included tests for the presence of bacteria through the Gram stain, cell count, and differential glucose and protein. A CSF PCR panel for CNS pathogens should be obtained. Also, a blood culture should be obtained at the same time, which also is to be obtained to assess for systematic infection. A CSF protein content is elevated due to the inflammation. A CSF Gram stain may demonstrate the etiological organism. Bacterial meningitis is characterized as a high CSF WBC count with many neutrophils, an elevated protein level, and a decreased glucose level, indicative of bacterial meningitis. This is why it's extremely important to order all the exams that we mentioned earlier and the lab work. It is important to note that both these physical examination findings of Kernig and Brudzinski signs are classically associated with meningitis but have low sensitivities and high specificities. Therefore, they have little diagnostic value for meningitis. A non-contrast head CT scan should be done in patients without signs of ICP, altered mental status, changes, and neurodeficits, and any signs of meningeal irritation before an LP to avoid the risk of brain herniation when CSF is drawn. For treatments, bacterial meningitis is a serious life-threatening disease that requires prompt and intensive therapy. Urgent empiric IV antibiotics treatment, such as ceftriaxone and vancomycin, is essential and should be started right away after diagnosis of bacterial meningitis is suspected or proven. Although obtaining blood cultures, neuroimaging studies, and CSF analysis is desirable and should be done immediately if feasible, they should not delay the administration of antibiotics. The rationale behind giving antibiotics right away is that it may reduce the risk of dying, and the sooner you give them the antibiotics and they are treated, the greater the chance that they will make a full recovery. Dexamethasone is a steroid medication. It's administered to reduce inflammation around the brain and its associated seizure risk. These patients may need to be promptly admitted to the hospital's critical care unit. The patients will have IV fluids, penicillin, steroids, and essential fluid, and nutritional replacements. This is why it's important for them to be in an ICU. Nursing care is extremely important on that unit as it includes monitoring neurological parameters for seizures and for any neuro changes in general, blood pressure, temperature, and fluid replacement. The neurologist will order a standard X-ray as well as a CT scan of the patient cranium to determine the extent of the swelling caused by the inflammatory presence of the bacteria. They will also put an X-ray every day just to see if the treatment is helping the patient progress the right way or not. Since bacterial meningitis is a highly infectious disease and poses a public health threat, physicians have to immediately report the case to departments of public health. The Center of Disease Control will assure proper follow-up with individuals that have been in close contact with the patient. These are my references. Thank you so much for listening. I hope you learned a lot. I really enjoyed doing these presentations. Thank you so much.